Hey, it's me, Jen again. Today's guest is no stranger to non-surgical thyroid interventions. We'll discuss two of them offered by Dr. Allan Golding coming up. From ethanol ablations to radiofrequency ablation, Dr. Allan Golding practices what is called Interventional Endocrinology at his practice in Hollywood, Florida. Rather than using medication or surgery, Dr. Golding can address structural thyroid issues while preserving a patient's thyroid gland.
You were in attendance in February at the Fort Lauderdale RFA training session that I was in attendance at. Yep. And I'm really curious to hear about how you ended up at that training and how later after that training you decided to take on thyroid RFA in your practice.
Well, we'd actually been talking about RFA in the practice for some time. Our most senior partner that's now retired was a bit of an enthusiast for the idea. We had been planning to introduce it for some time, but we were a little bit slowed down by the pandemic. But it was kind of serendipity that there was a course right here because I had done a lot of ethanol ablations and they're somewhat analogous in some ways because I had been doing, kind of semi-solid nodules just with ethanol ablation. So a lot of the approach is the same. The moving shot technique is all the same. So a lot of it is the same, but just using heat instead of a chemical for the ablation is kind of different. And I thought the course was going to be in my backyard. So then after that, we talked Memorial into buying the equipment, and we started doing cases this fall.
Did you have a lot of red tape to get through with your organization being willing to take this on, or were they very open to it?
They were very open to it. The approval process was pretty smooth and quick. Yeah. The mechanics of purchasing it was a little bit on the slow side. As far as the organization kind of embracing the idea, that was not really a challenge at all. Memorial's pretty good about that kind of thing, introducing new treatments and technologies and that sort of thing.
That's
one of the reasons I like practicing.
Well, that definitely makes your job more enjoyable, I'm sure. I can't tell you how many times I've heard horror stories about physicians who are in these big health systems having a really hard time wanting to bring these kinds of innovations into their practice. So it's a wonderful thing that you didn't have to go through that. You mentioned the ethanol ablations. Actually was watching the video on your website where you mentioned that you're offering a service that's typically available only in a specialized medical system. Are you seeing that ethanol ablations and now RFAs are really kind of a rare special treatment option?
I think we're pretty much the only place in our area that offers ethanol ablation. They send patients up from Miami and down from Boca Raton. I've been doing it maybe 15 years or so. It's kind of always been a part of my practice. RFA is new. I think there's maybe one other person doing RFA down in Miami.
It's great that you've been able to bring this on to South Florida because as far as I'm aware, there's one in Miami. And then the others located in Florida are on the west side of Florida, like in Tampa, Sarasota. There's one in Oviedo, near Orlando. And then I believe there's one at Jacksonville, Mayo. They're all kind of scattered across the state. There's not anyone that's really like close to another. I think that as more patients become aware of this, we're going to see more physicians who decide to take it on. It's becoming a highly sought after procedure. We've got patients in our Facebook group who will travel across the world even to get this done. Have you seen any patients come from far away, or are they mostly local?
So far, mostly local. So no international travelers. We have kind of an outreach program with some of the Caribbean countries.
Yeah, everyone's got nodules, even in the Caribbean.
We do have a number of nodule patients come over from particularly Bahamas. They come over, they go shopping, they get their nodule biopsy.
So what about the response? You said you've done several cases. About how many cases have you done?
We've done 3 so far. We've got another one scheduled later this week. And I think a couple more after that. So not a huge number so far, but all 3 have gone very well.
Well, you just said you brought this on like in the fall. So, I mean, considering that's pretty good. And you have this experience in your background of interventional endocrinology. If you could give us a kind of a layperson understanding of what exactly that is and how that sets you up for success in the RFA.
My background is as an endocrinologist, but I've been kind of focused on structural thyroid disease for 10 to 15 years, even predating when I came to Memorial. When I was doing it at Dartmouth, that was basically my role there. A large part of that is doing ultrasound guided procedures, a lot of biopsies. We do fine needle and core biopsies, ethanol ablations, and I've done that for a long time. And that is kind of more or less what my practice is. For kind of a lack of a better term to describe that, we've called it interventional endocrinology because it's the subset of endocrinology that involves intervening in some way beyond just prescribing medications. So all the ultrasound background, all the ultrasound guided procedures really, I think, is a good training for radiofrequency ablation because that is an ultrasound guided procedure involving a needle. It's important to get the needle placement correct. Otherwise, you could do some real harm. Thousands and thousands of ultrasound guided procedures that I've done I think really set me up well.
So many people talk about how having biopsies can be really a no big deal experience, and then others it can be traumatic when they're in the hands of a physician who's not really good at getting that needle in just the right place, procuring that specimen in a way that's not traumatizing to the surrounding structures. So definitely, having that background does set you up in a really good way to do RFA. And you were talking about how the ethanol procedure is so similar to performing RFA. Could you give us a little bit of a comparison and contrast between what those two procedures are like for patients? Because we do have a lot of patients in our Facebook group asking about ethanol ablation, or PEI is how we refer to it in the group.
Ethanol ablation, or PEI, is a procedure in which you inject 98 or 99% ethanol into a thyroid structure. It seems to be very effective for things that are highly cystic. 90% cystic and above really respond very well to that. What we do is, for a cystic nodule, we drain it. And I do this from the head of the bed in the same kind of configuration of the room as you would do for RFA. I drain it using a transisthmus approach, same as RFA. And we irrigate the cyst space with normal saline, inject ethanol into the cyst space with maybe a little bit of saline left in it, but not very much. So that's basically the procedure for a nodule that is highly cystic. I have done a number of nodules that are more spongy. They have solid components with a lot of microcysts. We've done some hyperfunctioning nodules that are fairly solid. This was kind of before RFA was widely available. I do those in the same way, from the head of the bed with a transisthmus approach, but instead of just injecting a cyst space, we're in a solid-ish or semi-solid nodule, and I use a moving shot technique for that, which is the technique that you use for RFA, where you advance the needle kind of to the back part of the nodule, inject a little bit, pull the needle back so it kind of moves more to the middle of the nodule, inject a little bit of ethanol, and then move it sort of to the front of the nodule, inject a little bit, and then repeat multiple times until we've kind of got little micro injections of ethanol distributed all throughout the nodule. And that's how I've been doing hyperfunctioning nodules and partially cystic nodules for some time. And that is a technique that's almost identical to what you would do with RFA. My first RFA case actually felt pretty familiar.
So when you do the RFA procedure, you're literally doing exactly what you just described, only you're dealing with a heated tip of the probe instead of injecting a liquid into this nodule. As you're explaining this, I'm kind of envisioning the same kind of idea as, say, you were going to be smoking a piece of meat on your smoker for the 4th of July, and you want to inject it full of marinade of some sort. You want it to be evenly distributed throughout the meat.
Same idea.
You're going to be looking for all of the injection sites throughout the meat to be evenly distributed. It's funny, I've talked with doctors about RFA and PEI for 2 years now, and I just had that kind of come to me. For a solid nodule, it makes sense that you would have to do it that way, because my understanding has been that typically it's only used in cystic nodules. But what's the comparison in efficacy between the ethanol ablation and an RFA ablation of hyperfunctioning toxic nodule?
RFA is actually quite effective for hyperfunctioning nodules. I haven't seen a lot of papers published recently, but there were some from kind of the 2000s. And there was a series from Italy of hyperfunctioning nodules. And this was kind of my inspiration for starting doing it when I was at Dartmouth. They had a near 100% resolution of the hyperthyroidism.
Wow.
And that's kind of been my experience too. I don't believe I've had any ethanol cases where they haven't resolved their hyperthyroidism, but I select cases for that carefully. RFA has a pretty good data for hyperfunctioning nodules as well. In fact, the last case that I did was a large hyperfunctioning, kind of minimally autonomous, because the patient really wasn't all that hyperthyroid. It was autonomously functioning.
The main appeal for that patient was probably the size reduction instead of the hyperthyroid reversal.
That is correct. That is what was motivating her, and it was large and somewhat symptomatic in addition to being a little bit overactive.
It's amazing that you can actually take care of both problems with the RFA procedure. I'm kind of circling back to what we were talking about with the meat injection of the meat with the marinade. So that's kind of how I was thinking about it as you were explaining it. And then when I think about RFA, I kind of think about using a wood burning tool on a piece of wood. Not exactly the best analogy because it's a 2D example rather than a 3D example. Mm-hmm. In a wood burning example, you're going to be putting that heated tip on the wood and burning out sections that you want to eliminate. And in RFA, you're going to be doing the same thing, only in a 3D way.
In 3 dimensions, yeah. You do one plane at the bottom and move up, do another plane kind of, part way up the nodule, get all that ablated.
I find it really interesting watching the procedure on ultrasound because to an untrained eye, which is what I have, not understanding what I'm seeing on ultrasound makes it very overwhelming to think that you can, with your knowledge and training, you can look at that fuzzy black and white image and understand exactly what you need to be doing and where you need to be treating.
So our first case, we had some observers in the room who were kind of watching it. Not all of them were ultrasonographers, but I think they kind of understood what was going on a little bit. There were some nice images where you could kind of see the needle, and then as I pulled it back, the track of bubbles that was forming in behind it. When you see that, it's pretty intuitive what's going on. With the ablation itself, you could kind of see once I finished that the entire nodule was darker than it was, with little bright specks kind of throughout it.
And that darkness, I kind of like to compare that also to when you burn wood with a wood burner. You're going to see a change in the color of the wood, and you're going to see the same thing on ultrasound with the thyroid nodule. It's going to change, as you said, to a darker color. Sometimes it'll become even irregular and kind of odd looking, almost like a malignant nodule would. So it's good to know beforehand that nodule is benign.
I emphasize this to patients that we are kind of fundamentally changing the appearance of this nodule. It's not really going to be something that someone can look at in future and make a lot of sense out of it. It's if they try to, it's going to look kind of ugly and potentially malignant to them. So I really emphasize that fact that if somebody does do an ultrasound later on, they need to know that this nodule was RFA'd and not just a really ugly looking nodule.
So do you have any kind of game plan as far as when you follow up with these patients who maybe are being seen by other doctors, maybe their primary care or someone else who would be evaluating their thyroid, to let them know, hey, don't worry about performing a biopsy on this nodule that looks a little weird because they have had RFA?
I send that back to the referring physician. But at least in South Florida, people often don't stay with one doctor for very long because of changes in insurance and that sort of thing. So I think the most important thing is that they should have a copy of their prior pathologies. We do, for the most part, require 2 negative biopsies prior to doing RFA for a nodule, and a copy of the op note. Then we do a post-op visit with them just by telehealth at about 2 weeks, and a copy of all that, so it's very clear to anybody kind of going through their records that something happened to that nodule and that it was benign, and regardless of how it looks now, that it's okay.
Let's talk about something that's a little bit funny, the popping that could happen during RFA. Mm-hmm. Have you experienced a good bit of that up to this point?
Oh, yeah.
Lots of popping?
Yeah, love the popping. I don't know if this is a universal experience for the patients, but they like it too. Yeah. Some of them do anyway. The case we did last week, patient was commenting after a big pop, like, oh, that was a good one. We do talk to the patients and encourage them to, to let us know if they're having any discomfort. So far, that's not really been an issue. A couple of instances where there was a little bit of jaw discomfort, and I just repositioned the needle and changed the power setting a little bit. That was pretty much it. Felt pretty good throughout, and they were talking to me throughout it.
It's a really well-tolerated procedure. That's what makes it so great, is the fact that it's so safe, effective, and well-tolerated. I think we have over 3,000, I want to say up to 3,100 members of our group now.
Mm-hmm.
In the last 2.5 years, I have seen maybe at less than 5 cases where the patient was like, oh, this was a terrible experience. I don't ever want to do this again unless I'm asleep. Everyone else is just overwhelmingly very pleased with how tolerable the procedure is, and then how much they see a change in a very short period of time. I wanted to ask though, regarding the popping, when you have popping occurring during this procedure, do you actually see anything happen on the ultrasound, or is it just a sound that we hear, but we don't really see anything to indicate there's a pop happening?
When there's a nice pop, you actually can see on the ultrasound kind of a big bubble form. There is kind of a visual correlate. You just kind of see this little white flash on the screen.
I would really like to see that sometime. If I could get a video clip of it, that would be really fun. I remember during my procedure, I had 1 or 2 really big pops that kind of like made me jump. How about we talk about your peers in the same part of the practice that you're in? How are they responding to the RFA procedure being there now at your practice?
Pretty enthusiastic. This is a hybrid practice. There's 4 of us in it. 2 are endocrine surgeons, Dave Bimston and Courtney Edwards. 2 of us are, quote, interventional endocrinologists, unquote, myself and Ivana Valenzuela. She's been doing some ethanol ablations, and I think she's going to add RFA. You met her in Orlando.
Yes, she told me that she was your colleague, but yeah, I was very excited to be at that training in Orlando too. And actually during that training, I got to be in the beginning portion of the actual hands-on where they were doing ablations on chicken. Mm-hmm. That was so cool. I had not seen that. And I actually asked Dr. Tofano if maybe I could do that at one of the next trainings I get to come to, because I just think that would be really fun.
Sure, you should. There's no reason why.
Would you say that doing the chicken is it really comparable to doing a nodule, or is it kind of not even close?
It gives you kind of a feel for what's happening internally. There's some popping with that too, so you're not really surprised by it when it happens. As far as being kind of adequate training, I don't know that would necessarily be the case. There's just so much ultrasound skill and practice that's required. Otherwise, you could lose the needle and burn something that you shouldn't
right.
burn. But it gives you kind of a feel for, kind of what it feels like to have a hot needle in tissue. It's worthwhile.
How many years of experience doing ultrasounds would you say would really be a minimum for a physician wanting to consider taking on RFA for thyroid nodules?
I personally feel that you would want to be doing this fairly exclusively for several years, at least 2 or 3 years at a minimum, before you kind of have the knowledge of the neck anatomy that you would need to have the practice putting needles into places where you want it to be, avoid, knowing what to avoid. Also, sometimes you're wanting to do hydrodissection. To move the thyroid away from the nerve or away from the carotid sheath or trachea a little bit. And that's not something that you learn right out of fellowship. I think you'd want to do a fair bit of diagnostic ultrasound and quite a bit of needle biopsy before you took on something like this. So I'd say probably a couple of years at least, doing a lot of this in your practice.
I think I've come to learn, and a lot of patients are coming to learn after we kind of dive into this whole world of RFA, is that not every physician does their own ultrasounds. A lot of them actually refer that out to other physicians or radiologists or imaging centers.
Mm-hmm. Yep. That's pretty common. The endocrinology group next door to us, the Memorial Endocrinology group, they don't do ultrasounds themselves. They either asked us to do them or send them to radiology. That's not so unusual. We've got some though that do their own and are quite good. Then we have some of our referral base that do their own ultrasounds, but they don't do procedures.
It's wonderful though when you do have that experience, because it allows the patient to come to you and have all of that done in-house instead of having to go back and forth from place to place, in the process of their diagnostics and, treatment options. I think that's something that patients are really interested in finding, is a physician who does do their own ultrasounds and biopsies.
Yeah, that's kind of always been part of our model. For patients coming in with nodules that require a biopsy, almost all of the time we will do a diagnostic ultrasound and the fine needle aspiration biopsy all in one visit. It makes it a lot easier for people. For patients that are coming in that are, surgical candidates, right? They're sent in to see us for surgery. We do pre-op imaging at their initial visit in the office, and we don't need to send them out for pre-op imaging unless we're doing CT scans or something like that. We try to minimize the amount of trips.
It minimizes their anxiety too, because every time they have to go to a different doctor and there's another explanation given and there, more co-pays and whatnot, it's a whole lot more anxious for them. And so they definitely like that whole in-house situation that you're describing. Did you have any final thoughts that you wanted to share about thyroid nodule care or RFA or PEI that, you just want to let the world know about?
I practice in an endocrine surgery practice. When you come to see us, it's, I think, maybe the best of all worlds, because we offer kind of the full spectrum. We can do non-surgical interventions to resolve a cyst, prevent it from recurring, to shrink a symptomatic benign nodule, potentially treat a small intrathyroidal malignancy. But if it's a case that requires surgery, we take care of that too. So we really can offer multiple options. I think that is good for patients when they can have the entire kind of spectrum of options available to them.
Absolutely.
Thanks so much for watching. Make sure you subscribe and ring that little bell so you don't miss the next video. I have lots of exciting content coming up in the near future about RFA, PEI, laser ablation, traveling for treatment, and so much more. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.